Next talk is by Dr. Professor Subhash DADEYA. He doesn't need any introduction, and he'll be talking on monocular elevation deficiency, modified Nishidas procedure, current status. Professor Subhash, please.
Very good morning to one and all. Thank you, respected chairman, sirs, and dear friends. Basically, monocular elevation deficiency is characterized by limited ability to elevate the affected eye in any gaze position while maintaining normal reductions in all other gaze. And this MBD is classified into three types. Initial term was double elevator palsy, which was coined by Dunlop. It may be congenital or acquired, paretic or restrictive, supranuclear. However, MED is more accurate term as there can be paralysis of both muscles independently, and supranuclear lesions can lead to impaired unilateral upgaze palsy. It is classified into type 1, type 2 and type 3. In type 1, there is tight inferior rectus with positive FTT for inferior rectus, poor bells. In type 2, there is primary superior rectus palsy and ability is free for inferior rectus, and type 3 is supranuclear with good bells, negative FDT, and intact scatic velocities below midline and normal above midline. Patient can present with vertical misalignment of eyes, drooping of upper lid, diplopia, abnormal head posture, inability to elevate the affected eye, and decrease in vision. There is presence of hypotropia, presence of ptosis and pseudotosis. There is limitation of elevation above midline, which is equal in all three horizontal gaze. This is adduction, primary position, and abduction. Bell's phenomena is absent in IR restriction and SR palsy. Amblyopia is seen in congenital cases. Abnormal head posture, typically chin elevation is there. So this is clinical photograph of patient of left MED showing all features. Another case of MED. Another case of MED. Then we have to differentiate between congenital and acquired MED. This is a 20-year-old female with post-traumatic MED, and FDT was suggestive of tight IR. It may be congenital or acquired. In congenital, it is primary inferior rectus restriction, superior rectus paresis, and supranuclear palsies. In acquired, it may be due to trauma, tumors, cerebral vascular diseases, metastatic tumors, sarcoidosis, cysticercosis of muscle, and thyroid eye disease. So it is very important to differentiate congenital MED from acquired MED, and most important feature is presence onset since birth, and secondly presence of strabismus and ptosis are the features of congenital MED, while acute onset diplopia in primary gaze and upgaze is seen in acquired MED, and ptosis is usually not a classical feature of acquired MED. Investigations are systemic workup, thyroid profile, X-ray, CT, MRI, USG. These are the various differential diagnoses for congenital and acquired MED. This is case of acquired MED due to cysticercosis and was treated. And these are the photograph after oral albendazole and steroids. Indications for surgery are abnormal head posture, significant vertical deviation in primary position, contracted binocular fields, and diplopia in primary position, and in some cases only observation is required. With limited head changes, patient can maintain orthophoria. Goals of surgery are to achieve cosmetically acceptable deviation in primary position, to increase the field of binocular vision, to counsel the patient that more than one surgery is required. Ptosis surgery should be done after strabismus surgery, and it cannot cure MED completely. Various treatment options are NEPS procedure, modified NEPS procedure, augmented NEPS procedure, vertical muscle resection, contralateral superior rectus resection, contralateral superior rectus resection with Fardens, resection of inferior oblique, resection of contralateral inferior rectus, and recently this modified Nishidas procedure has been tried in MED. So what are the drawbacks of NEPS procedure? It is not a graded procedure. Residual hypotropia is there, horizontal deviation is there, then difficult to treat, horizontal motility restrictions, hypertropia which worsens with time, diplopia and lower lid retractions, and anterior segment ischemia is there is risk of anterior segment ischemia. So this Nishidas procedure, due to its success and versatility, this procedure has been applied to range of other clinical situations, including Duane's retraction syndrome, third nerve palsy, transected medial rectus, MR hypoplasia, and sixth nerve palsy. And recently, there were case reports of Nishidas procedure being tried in isolated cases of MAD. So, in a study by Murthy et al., this Nishidas procedure was performed in addition to IR recession in 2 patients of MAD, and only in 1 patient this Nishidas procedure was done, and correction attained was that they were able to correct approximately 30 prism diopter of hypertrophy in conjunction with inferior rectus recession. It was 40 prism diopters of the correction. Then another study was done by Sweta et al., and in that study they have treated 7 patients in which they have done full tendon modified Nishidas surgery, and the average correction was around 52 prism diopters. So based on these reports, we have given a thesis at our center, and one study was done at our center in which we have taken 15 patients which are more than 13 years of age with MAD. And the inclusion criteria are patients with type 2 MAD with a hypertropia of more than 10 prism diopter and FDT negative for inferior rectus, and no horizontal deviation were included. And these patients were followed up at 1 week, 4 weeks, and 12 weeks. And surgical outcome was considered successful if post-operative alignment was within 5 prism diopter of hypertrophy, and results were analyzed at 3 months. Majority of the patients they were 15 to 19 years of age, and in our study, the mean preoperative hypertropia in our study was 28.67, and by 12 weeks post-operatively, we were able to achieve success rate in 10 patients. These are the changes in vertical deviation, preoperative and post-operatively. There was improvement in elevation deficit also. This is the table showing change in elevation deficit. There was improvement in torsion in approximately 66% of the patients. This is 9-gauge photograph of patient of left MAD with 30 prism of hypertropia, and this is a post-operative photograph at 12 weeks. Another patient, preoperative and post-operative photographs. This is another patient with pre-op and post-operative photographs. So to the best of our knowledge, this is the first study to assess the efficacy of Nishidas procedure alone in significant cohort of MAD patients, and this procedure offered several benefits as it avoids muscle splitting or tenotomy, thus making it less invasive option with minimal or no risk of anterior segment ischemia. This is reversible procedure which improves vertical deviation and elevation deficiency significantly in patients of MAD. In our series, we have seen that in those patients in which deviation was, hypertropia was less than 30 prism diopter, this procedure was found to be successful. And in those patients, if the deviation was more than 30 prism diopters, this procedure was not found to be successful, and we have to reverse the procedure and do the NEPS procedure in those cases. Thank you.
Thank you, Dr. Subhash.